The next speaker is Shamik.
Very good
Shamik
afternoon, one
Ladappa,
and
yeah.
all. At the outset, I'd like to thank the AIOC 2025 and my own Vidarbha Ophthalmic Society for giving me this opportunity to speak on this podium about ocular infections, and especially I'll be talking about presumed ocular tuberculosis and the role of AKT in managing the same. So as we all know, tuberculosis, Mycobacterium tuberculosis is the major cause for infectious diseases, especially so in regions which are endemic to tuberculosis. Almost more than a third of these patients of infectious uveitis turn out to be Mycobacterium tuberculosis. And a third of mycobacterial tuberculosis uveitis would end up with a visual acuity far less than what most of us don't even want to expect. It's less than 3 by 60. And a third of these patients tend to develop other comorbidities related to the uveitis like glaucoma, secondary glaucomas, and macular disease, including the scarring of the retina. So the definitive diagnosis, as they say, is elusive, but I say I would want to rephrase this particular line and say that it's basically our ignorance towards the presence of Mycobacterium tuberculosis as a major cause of uveitis. And that's what is very obvious from the way and the pattern in which uveitis is mostly treated in our part of the world. Despite the fact that India remains the biggest tuberculosis endemic region in the entire world. So the cornerstone for investigation has always been the MANTU test, the skin test, skin tuberculin test. And a strong positive MANTU, as they say, is a definite sign of an exposure of the patient to tuberculosis, Mycobacterium tuberculosis, and uveitis in such patients. You can easily say that if there is a strong positive MANTU, meaning more than 20 millimeters of induration, you can be very sure about it. But in cases which are ambiguous, Dr. Ratinam, my mentor, she always says that do a booster MANTU. I mean, she relies on MANTU that very much to again go on to prove that this is a case of tuberculosis. So, but still, if there is ambiguity, then we have the IGRA tests, especially in the endemic regions. The positivity of IGRA is a very high specificity, almost 70 to 80% specificity, as far as diagnosis of MTB uveitis is concerned. Usually, tubercular uveitis doesn't present itself in a very fulminant fashion, very rare. Usually it goes on over days, weeks, and months when the disease process starts affecting the patient's normal life, and signs and symptoms become very obvious. Likewise, the inflammatory markers also don't show a very increased number. It's a moderately high ESR, a moderately high C-reactive protein, and again, that is kind of with a positive skin test and an IGRA test, you are sure that you are looking at a case of Mycobacterium tuberculosis uveitis. And of course, if you can prove pulmonary or extrapulmonary tuberculosis, then more or less your diagnosis is confirmed and you can proceed with the treatment of the uveitis with AKT. The PCR tests of ocular fluid is again catching up. It's slightly demanding, but then still, if it is proven, then it is 100% bullseye, as you would call it, and you can initiate your treatment to treat the uveitis by putting the patient on anti-cox treatment. But what drives most of us when we are treating patients with uveitis is the classical clinical findings that you see. I picked up these slides from one of the uveitis group. If you see these multiple tiny nodular lesions in the conjunctiva or a painful localized inflammatory nodule on the sclera, the fleshy, greasy type of keratic precipitates with iris nodules, or as Dr. Amod Gupta has and his group has clearly shown us, a broad-based posterior synechia, or if you have an inflammatory involvement of the optic nerve presenting as disc edema, a well-defined elevated lesion with peripapillary fluid and hemorrhages causing disc edema and vision loss, or if you see these subtle RP level lesions which have hyper autofluorescent margins, or if you see a solitary elevated choroidal lesion, a choroidal lesion with exudative detachment, or these multiple yellowish choroidal tubercles with central clearing, or periphlebitis or occlusive phlebitis, as you can see in the slide, uh, or a branch vein occlusion which is resulting from perivascular inflammation. So these are some of the cases where you can be sure that you are looking at, you should have a very high index of suspicion that the patient is suffering from tuberculosis, and the uveitis is basically because of that. Pathomechanisms, there are many, but what is proven is that probably the tuberculosis either involves because of direct invasion, or it is the induction of specific antiretinal immune response to the Mycobacterium tuberculosis antigen, or a combination of both. Here I would like to stress upon the role of retinal pigment epithelium in somehow controlling the spread of Mycobacterium tuberculosis in the eye. It not just incites the inflammatory cascade, but it also regulates how much inflammation is drawn towards controlling that MTB without damaging the ocular tissue. So RP does play a very important role. And of course, the retinal vasculature also, the blood retinal barrier, a part of that also limits the spread of the disease. And you will see these vasculitides and all in tuberculosis primarily because of the inflammatory response, the blood vessel lining, actually the retinal blood vessel lining that it throws up. Again, the same picture telling us how the T cells and the cytokines are liberated to control the and limit the spread of the disease. And what's important is that tuberculosis doesn't kind of present in a very classical manner. It presents in variable phenotypes. So that's another reason why at times you get confused and you're not very sure. There is not a perfect clinical sign that you could say, okay, this is tuberculosis. And of course, a lack of a proper investigative tool that you can 100% trust. But in any case, different criteria have been adopted by different groups, the Sun group, the COTS group, the Gupta et al. Group, and they have all kind of told us what all you should do when you are suspecting uveitis because of MTB. Histopathologic isolation, positive IGRA, MANTU test, serology that rules out other infective disorder etiologies, and also to rule out sarcoidosis, because sarcoidosis is the closest differential diagnosis to tubercular uveitis. Chest radiography, and of course to try to confirm extrapulmonary COX. So from diagnosis, let's move on to the treatment part. Of course, a clear response to AKT in a case of uveitis is the most, that is the clearest sign that you are treating a patient with uveitis. There can be no other thing that you start the patient on AKT and the uveitis resolves. I think that is the clinching diagnosis that you are treating a patient with uveitis, and then you should not let it go and continue all the way. Steroids and immunosuppression are the cornerstones for treating any uveitis. And there are multiple studies wherein they have actually proven cases of Mycobacterium tuberculosis related uveitis, which they have treated solely by treating the patient with antibiotics. And there have been multiple studies where they have shown how merely treating with steroids has been detrimental to the cause of treating TB uveitis. But more or less, if you treat the patient with AKT, on the contrary, if you treat the patient with AKT, your chances of 100% success in managing the uveitis, which is related to TB, is there. And there are so many studies that go on to say that. So there is a definite role of treating the patients where you are even suspecting a patient with Mycobacterium tubercular infection with AKT. I think you are doing well by treating the patients this one. And of course, as I said, the problems are because there is no gold standard diagnostic test, and the variable phenotypes with which the TB presents, and lack of awareness within our own fraternity also leads to lack of proper treatment. So what are the drugs? Basically, the traditional treatment is the 4-drug treatment. You start off with the 4 drugs in the initial 2 months, and then there is a maintenance phase of 4 months. WHO also recommends a 4-month ATT treatment, 2 months of isoniazid, rifampicin, moxifloxacin, and pyrazinamide, followed by all the other drugs except pyrazinamide for the next 2 months. So this is another way. But most of the groups that have been studying TB uveitis always propose that you try to extend the treatment. Once you get a good response with AKT, don't stop at 6 months. Continue for 9 months or 12 months, because that is where you are able to then control the disease properly, and the chances of relapse are far less if you are treated them for a sufficiently long period of time. And there are so many online calculators which you could use, that I have mentioned it one over there, to find out the median score and then decide whether to recommend the patient for AKT or not. Use of systemic steroids concomitantly with AKT is definitely a good way of treating TB uveitis. You can't do without the steroids, but first control the infection and then start with anti-inflammation. That's my basic take home. And there are so many other drugs which are now available in our arsenal to manage TB uveitis. I rather not go into that. That's beyond the scope of this topic. I thank you for your patient listening.
Shamik, I just wanted to ask one thing. Because these drugs are potentially toxic and have their side effects. So, yes, what is your protocol for following them up for avoiding the ethambutol toxicity?
Ma'am, basically, ethambutol toxicity, yes, we should have. Whenever we start the patient, the basic thing is that follow up the patient very, very rigorously. You can't just leave the patient just like that. Now, there is a watchdog from our own government of India who, once they start the patient on AKT, they are following them up very nicely. If the patient complains of any vision related thing, it could be because of uveitis, because there are flare-ups which are happening. But one needs to have that thing in the mind that we are treating the patient with ethambutol for a long period of time. So there can be a chance of toxicity. So follow-up, I think, ma'am, should be the right thing to do.
Even the dose calculation, because these are these toxicity occur because of the cumulative effect dose. Of the drug. So yes, sometimes that is exceeded, and yes, patients suffer permanent visual loss because of the treatment.
And so as a rule, ma'am, there is one thing that I wanted to add. All of us are doctors and we are well versed with treating patients with AKT, all right. But I think the chest physicians do a very good job with the management of such patients. They know, they can identify the side effects of these drugs. And so always when you are starting the patient on AKT, it's a good idea to involve a physician in the process. Same thing with management with immunosuppressives also. I think if you have a good rheumatologist friend and a chest physician with you, I think you are doing well in treating your patients properly.